Hello, I'm Dr. Jerry Lowder. I'm a urogynecologist at Washington University in St. Louis. And I'm currently the American Urogyn Society Publications Committee Vice Chair. And I'm here today with Dr. Daniel Biller to discuss a recent publication by the AUGS Payment Reform Committee entitled Developing an Advanced Alternative Payment Model for Stress Urinary Incontinence. Dr. Biller, would you like to introduce yourself?
Sure, thanks, Jerry. I'm Daniel Biller. I'm a professor of female pelvic medicine and reconstructive surgery at Vanderbilt University in Nashville, and was lucky enough to serve with Jerry as the vice chair of this committee and then subsequently the chair.
Thanks, Daniel. And to all, for full disclosure, I did serve on the Payment Reform Committee during the development of this paper. And again, appreciative that Dr. Biller will agree to be interviewed for this. So if you don't mind, Daniel, can we start off and discuss a little bit about what an alternative payment model is?
Yeah, absolutely. So an alternative payment model is a payment approach that gives added incentive payments to provide high quality and cost-efficient care. So these APMs, as we call them, can apply to a specific clinical condition, a care episode, or a population. Advanced APMs is a track of the quality payment program that offers incentives for meeting participation thresholds based on your levels of payments or patients through advanced APMs. So back in 2015, the Medicare Access and CHIP Reauthorization Act, also called MACRA, was signed, and this resulted in profound changes in the financing of Medicare programs. So it was driving the policymakers hoping to drive a healthcare spending from fee-for-service to interventions that create value. So in our world now, in value-based care, it means really adhering to the value equation where value equals quality divided by cost. So using that as a paradigm, we can increase value by either increasing quality in the numerator, right, or decreasing our cost in the denominator. So MACRA was significant because it repealed the sustainable growth rate called the SGR, which has been used for many, many, many years. And it substituted the SRG, or that sustainable growth rate, and its fee-for-service reimbursement model with a two-track system that requires physicians and other clinicians to accept downside risk. So MIPS, or the merit-based incentive payment system, and the alternative payment models are what were created. So these systems add quality measures to fee-for-service payments for medical care. And these systems also financially penalize those clinicians who are not achieving quality performance measures. So when CMS did away with the SGR, the sustainable growth rate, we're now able to reward high value, high quality Medicare clinicians with payment increases, while at the same time reducing payments to those clinicians who aren't meeting performance standards. So ideally, an APM would lead to improvements in outcomes by promoting adherence to evidence-based pathways, maintain or improve safety and effectiveness, and or reduce the cost of delivering care.
Thank you. And so why do we need an APM for stress urinary incontinence?
So evidence-based guidelines and clinical pathways can be linked to costs from administrative databases and outcomes from surgical registries for the treatment of stress incontinence. And that would promote the delivery of value-driven care. The treatment of female pelvic floor disorders, such as stress incontinence, is facing significant changes in reimbursement. And those changes will drive our practice in healthcare delivery in the United States. The American Urogynecologic Society, AUGS, created our Payment Reform Committee in 2016 to spearhead our society's efforts in developing these payment models for pelvic floor disorders. And we decided to start with stress incontinence.
Excellent. And so in particularly, why was the diagnosis of SUI or stress urinary incontinence chosen?
Well, interestingly, stress urinary incontinence was chosen due to the perceived straightforward nature of the condition and the significant incidence and prevalence of the condition in our practices of all of our members. Stress incontinence is common. It affects 25 to 50% of women. It costs up to $12 billion annually in the United States. And of all the pelvic floor disorders that our AUGS members treat, stress incontinence was, at least theoretically at the time, the least complex. So an APM for stress incontinence should have been a good starting point for APMs, as opposed to more complex pelvic disorders such as pelvic organ prolapse. And then finally, women with stress incontinence are treated by a diversity of healthcare providers, primary care physicians, general gynecologists, urologists, FPMRS specialists. We also have numerous treatment options, including behavioral modifications, physical therapy, continence pessary use, and surgical interventions. So an APM that is acceptable to multiple healthcare clinician groups and encompasses numerous treatment strategies, we thought would serve as a model for APMs and for other pelvic floor disorders.
And so what barriers or difficulties did the group encounter in developing an APM for stress urinary incontinence?
Well, we certainly encountered many barriers and difficulties, without a doubt. The care for women with urinary incontinence can range from straightforward to complex, both within stress urinary incontinence itself, as well as urinary incontinence in general. The care varies by region of the country and ideally would require the coordination of care amongst multidisciplinary teams led by FPMRS specialists. So the barriers that we ran into included that conceptual framework of modeling care of a patient presenting with straightforward stress incontinence. We all know inherently the evaluation care for a patient with urinary incontinence is significantly variable. So patients can present with what we call straightforward stress incontinence. They can present with mixed incontinence, stress predominant incontinence. And as we all know, we tend to use this saying with our patients quite a bit. You know, the bladder is a very poor historian. So often what we think of straightforward stress incontinence is not exactly straightforward. So our goal was to develop an episodic care model with evaluation and treatment window, including surgical management and categorizing the care into preoperative care, surgical care, postoperative care, and continuing care. In treating stress incontinence and tracking costs and outcomes, we recognize that as stress incontinence is treated by surgeons, by nurses, by physical therapists, by advanced practice nurses. It can occur both in the ambulatory and hospital setting, each with separate billing mechanisms. Subspecialists and ancillary services have not historically been included in joint or shared payment models or risk-adjusted payment structures. Outcome measures haven't been standardized, routinely assessed, or benchmarked. So the majority of our outcome measures are developed in the context of clinical trials, and we had a significant issue deciding whether or not they can be directly applicable to standard real world practice. And finally, true estimates of costs for treating stress incontinence are difficult to ascertain from the medical and insurance system. What we found was considerable variation in evaluation and treatment of stress incontinence, including a large cohort of non-surgical management mechanisms. So we came to recognize that simple stress incontinence, as we call it with quotes, is less common, particularly in the practice of our AUGS membership specialists. Additional pathways were developed for stress predominant and mixed urinary incontinence, urge predominant mixed incontinence, recurrent stress incontinence after prior treatment, stress incontinence with pelvic organ prolapse, occult stress incontinence with pelvic organ prolapse, and stress incontinence due to intrinsic sphincter deficiency. All these were variables that made our assessment more complex. We found a significant overlap between evaluation and management of these stress-related disease states.
And then, as far as using administrative database to obtain cost estimates, what challenges did that present?
So we were lucky enough to be able to acquire a Medicare database of all the beneficiaries from a particular time period, as you see in the paper. And what we found was that there was significant variation depending on who was providing care, depending on the area of the country where that care was provided, depending on the utilization of resources or lack thereof. We found we were unable to ascertain some of the details that would help us tease those costs out. Oftentimes our cost data that we were able to extract from the database traversed multiple years. And again, we had a starting and an end point. And so it was not always possible to follow those patients across those timelines. Those were some of the more significant issues we ran across with using real life database.
And the data also confirmed, as you mentioned, that delineating or defining kind of simple stress urinary incontinence is very difficult in an administrative database as well, and then thus the actual cost, real world cost of treating it. So why should AUGS members read this paper?
Well, I think that our membership would benefit from understanding where our healthcare reimbursement is going to value-based care. How do we increase value? Again, going back to that value equation. In a constrained environment with limited resources, we really need to focus on both sides of that equation. This paper goes into detail about how our group, and by the way, Jerry, we should have mentioned and thanked all of the people in our group, because this was certainly a group effort of very smart people putting in lots of time, with voluntary time to do this. And what we found is that we need to do better at benchmarking. We need to do better at identifying what metrics we want to call value. Again, most of those metrics come from our controlled trials, and again, are maybe not relatable to real world. We need to be able to create some care pathways based on evidence. On the cost side, I think it's important for all of us to recognize that as we move from a fee-for-service reimbursement model where we are rewarded for doing more, as we move into a value-based, we may be rewarded for doing what's necessary, which many times may be less. So can we reduce cost? Can we reduce the amount of diagnostic testing that is maybe not necessary? For instance, if a patient is not moving towards surgical intervention for stress incontinence and instead maybe wants to move forward with physical therapy or a continence pessary, is it necessary to perform multi-channel urodynamics? I don't pretend to know the answer to that, but what I do know is that maybe different pathways are appropriate for different patient populations. And simply asking those questions within the framework of value-based reimbursement is valuable. It makes us think about how we deliver care. What do we offer our patients? Are we offering what's best for the patients? And are we offering what's going to provide that patient the most value? I think more than anything, reading this paper gives, as I went to reread this paper, it gives me a better understanding of what we're doing, why we're doing it, and how can we improve the experience for the patient and decrease the cost for the system.
Excellent. Well, on that, I would like to thank you for taking the time to participate in this interview. And like you mentioned, we'd like to thank all the members of our working group that developed the paper, and definitely to encourage all the viewers to look up the paper and read it. So again, Dr. Miller, thank you for your time.
Thank you, Jerry.